All right, everyone. I think we're going to get started now. So, hi, everyone. Welcome to Effective Altruism, University of Melbourne's Mental Health in the Developing World with Victoria Baranov. My name is Aravind, the former president of Effective Altruism, Unimelb, and I'll be co-hosting this event with Max, our events director. Thank you all so much for coming. We're really grateful you've taken the time to come along, and we hope you come out of this learning about the really neglected field of mental health in the developing world. So in today's event, we'll start with Victoria giving a 20-minute or 30-minute presentation on her work so far, and then we'll move into a Q&A for the remainder of the event. Feel free to use the chat function to submit any questions you have at any time during the event and during the Q&A, and we'll ask them in due course. So before I introduce our guest Victoria, I'd also like to invite you to join Effective Altruism Unimelb or EA Unimelb using the membership sign-up link below, and like and follow our Facebook page as well. We have a lot of cool events coming up. Effective altruism is a movement that seeks to answer the question of how we can do the most good with our limited resources available. And we run in-depth discussion events, career workshops, guest speaker discussions like these, and a whole range of social events. EA Unimelb is particularly known for its warm community. So if you're looking for some new friends interested in making the world a better place, we'd love to see you at our next catch-up. So now to get on to the main event this evening, our speaker, Victoria Baranov, is a development economist and a senior lecturer at the University of Melbourne Department of Economics. Her research concerns the role of physical and psychological health in the poverty cycle and the interactions between poverty, mental health, and behavior. Her work, which we'll talk about today, has included developing and assessing mental health interventions in developing countries such as Pakistan and East Timor. So Effective Altruism is interested in Victoria's research because mental health is frighteningly neglected, and the scale of the suffering it inflicts is vast. Self-harm, mental, neurological, and substance use disorders cause 12% of the global burden of disease, while receiving a median government spending of 2.4% of all healthcare spending. So there is a clear imbalance in the ratio between mental health disease burden and the healthcare spending, ranging from 3 to 1 in Canada and the USA to 435 to 1 in Haiti. The lack of effective funds dedicated to this issue contributes to the fact that 78% of those with mental health illnesses in high-income countries and up to 96% in low-income and low-middle-income countries do not receive treatment. So that massive treatment gap indicates the need for more effective organizations and funding and interventions to solve this problem. So I'll now hand it over to Victoria whenever you're ready.
Great, thank you so much. Thanks for the kind introduction, Aravind. That was really, really nice. And I think you really hit upon the major issue, which is obviously that mental health is definitely, a big global burden of disease contributor. And in fact, it's the leading contributor. Mental ill health is the leading contributor to the global burden of disease. And it is gets the least amount of funding in terms of health spending, and particularly low in developing countries, where it's been thought for a really long time that mental ill health, like depression and anxiety, these were sort of the diseases of the rich or disorders of the rich or the affluent, which is, of course, has really been turned on its head for in the last 20 years of research. But I would say less than that in terms of how that information has actually spread and become well established. So I'm gonna share some slides so that it's not just my face talking, I guess. And here we go. Hopefully you guys can see everything okay and you can hear me all right. All good. Great, thank you. Yes, so yeah, well, that's basically the introduction. Was already sort of given a little bit by Aravind, and then so I'm going to assume that you agree that mental health is important. From a big picture perspective, we care about people's happiness and well-being, and so we should care about these as outcomes in the same way that we care about their physical health, their incomes, and so on. So we fundamentally care about happiness and well-being. Those are the ultimate goals, right? And so we care about the people's mental health because those are important. That's an important contributor to health and well-being, or happiness and well-being. But also, mental health is potentially important for other things. So it's not just an outcome. It's not just the thing that sort of you are trying to. But it's not just well-being. It's not like happiness where you're thinking about it as, everything that you do is sort of leading you to get higher well-being or happiness, but rather mental health is potentially itself actually productive. So what we mean by that is that it affects the way that you work, how well you work, how creative you are, how much effort you sort of put into various tasks, or how much focus you can, put into things. So mental health is important because it affects your ability to do things, both in terms of things that, lead to greater income, but also potentially things that make you happier as well. And so mental health, this sort of effect that mental health has on behaviors, and what I'll focus on is economic behaviors, it potentially causes what we would consider sort of a psychological poverty trap. So I'm going to talk about that in a little bit in 1 second, but I just wanted to also flag, in terms of mental health being important, just in case you didn't know, but this week is actually Mental Health Week. So on Saturday, it was World Mental Health Day, and this was just the WHO recognizing World Mental Health Day, and the fact that development assistance for mental health has never exceeded 1% of total development assistance for health. So this is just, again, restating what Arvin had already said, that like it is clearly, it is an important outcome that we care about, but there's actually even more to mental health than just it being an outcome. It is potentially a productive input that we should care about in a way that can cause a vicious cycle of poverty. So what do I mean about that? What I mean by this sort of vicious cycle of poverty, by that I mean poverty itself causes stress. It's basically characterized by a lot of economic uncertainty, obviously low amounts of resources and scarcity. It's characterized by a lot of adverse shocks, health shocks, mortality shocks, income shocks. So a lot of negative, bad things happening without much support to help you out. And all of these things, basically contribute to making poverty a very stressful state. It's stressful, both sort of physiologically stressful and also psychologically stressful, just keeping all of the things that are happening in your mind, but also the fact that like things that might be happening are quite bad, especially if you're sort of seeing high levels of infant mortality. If your children are dying, that is obviously going to have very negative consequences on your psychological well-being. So we think that we have very good evidence to link poverty to psychology. In other words, that there is a causal effect. It's not just a correlation that we found. We know from a lot of studies at this point, randomized studies, which are really, sort of a solid type of foundation for trying to understand the way that, causality works. We know that when we alleviate poverty, we improve people's psychological well-being. So we really think that there are this link between poverty and poor mental health is pretty strong. So if poverty leads to poor mental health, for example, sort of depression, by way of just being constantly exposed to chronic stress, then this becomes a poverty trap if there's also a causal effect of poor mental health on economic decision making. So this is what I alluded to earlier in terms of how mental health might impact productivity. So say someone is depressed. If someone is depressed, then they might be overly pessimistic. They might feel like everything is just really, really hard to put in effort. They might not be able to focus very well. So these are the types of things that might affect the way that they make decisions, especially in a systematic way that makes individuals who have poor mental health basically make decisions that are suboptimal, at least from like an economic sort of perspective. Like they might not, be as productive at work. They might get fired as a result, and then they will have lower income. And so so that's one example of how basically this becomes a vicious cycle, right? So, they're poor to start. They might have, already a bad job. They might have exposure to negative shocks. Then, they have depression. then they are not so attentive at work. They might get fired or lose their job or lose, you know, their harvest. If they're actually in the developing world, they're much more likely to be subsistence farmers, so they might not have a great harvest. And so now then they're going to be poor again in the next seconds, and this keeps feeding itself. So poverty itself creates this psychological state that reinforces poverty. And what we know is poverty is very persistent. And so we have thought about different types of poverty traps as economists. So this one is a psychological one. There are other poverty traps that as development economists, we have also studied. For example, the nutrition poverty trap. So you can, instead of thinking about psychology here, you can think of as having, you know, basically enough food or enough calories to work. And so this is in a very sort of subsistence type of sort of state where, you know, people are basically so poor that they don't have enough calories, and they can't buy enough calories to ever really get enough energy to actually get work done in the field, for example, if they are subsistence farmers. And so this sort of perpetuates a cycle, and they never can ever get out of that cycle unless somebody, you know, gives them a big infusion of cash to get over that hump and actually gain enough strength to then be productive. What we know from the sort of nutrition-based poverty trap at this stage is that basically calories are very cheap to buy, and it's very unlikely that actually there's any sort of evidence of nutrition-based poverty traps. So there's other types of poverty traps, like not having enough savings or credit. I won't talk about those. I'm just going to mention that this is, you know, the idea of a poverty trap, that's something that creates this vicious cycle that is difficult to break, is sort of a key in development economics, in part because what we know from that is that a lot of other policies that we might try might not be very effective because we never get over the sort of, we never get over the hump. There's something else that is sort of blocking, it's actually blocking the effectiveness of other types of interventions. So as an example, if we provide credit to individuals, if they don't have any money and they want to invest in a productive asset, we might say, well, why don't we just give all of the people who are poor and who are interested in, you know, sort of buying a productive asset, we give them microcredit or microloans. So as you're familiar with, that's a really big revolution in giving. The microfinance revolution received the Nobel Prize. And what we actually know from all of that is that, like, providing access to credit for people didn't seem to be the silver bullet that we thought it would be. People, you know, get credit, but they still don't produce enough to get out of the poverty trap. And so it hasn't been the silver bullet that has enabled individuals to come out of poverty and you know, regions to come out of poverty in very rapid ways. And what might be happening is that there is, in addition to sort of physical constraints or constraints such as credit or, you know, access to education, etc., there's also potential for psychological constraints, such that when we provide these other types of interventions, we like access to credit or access to, you know, health-saving technologies, people are not attentive enough or just so psychologically so beaten down that they're not able to sort of respond to those. And so that's why the psychological poverty trap is potentially really important, and it's a kind of a new research area. And so what we know, and what I'll show you in a second, is we know this link that because we have a lot of examples where we have provided cash transfers randomly through Give Directly, for example, if you're familiar with that organization, it just provides cash transfers via mobile banking to poor people. So it takes your dollars and it just deposits them in people's mobile banking accounts, which is great, and really, like, sort of highly regarded organization. Effective Altruism supports that as well, I believe. And so via government cash transfers, via give directly type studies or programs where we have many studies that have shown that alleviating poverty improves mental health. It reduces stress, it reduces depression, it improves life satisfaction. So this arm we know well. What we don't know nearly as well in terms of, is there a causal effect of, poor mental health or depression on economic decision making? So what I mean by economic decision making, it's very broad, is, investments, future investments, work effort, investment into the children. So for example, education for children, etc. So these things that we sort of know are important determinants of poverty, basically, right? So these are the things that lead to income, either for the individual or for their children. And so what we don't know, and the reason we don't know this is because it's really hard to get a causal sort of understanding. What we can see in the data is we can, look at the data and we look at correlations or associations between depression and poverty, for example, and we see that they are positively associated, right? So the higher the poverty rates, the higher the depression rates, etc. So, but that of course could be because of this channel. So, this is, precisely because of the sort of vicious cycle, you're going to find this association in the data. So the question is whether or not, if I shut down one direction of this loop, if I just isolated mental health or depression and I change that, should I expect if I take a person who was depressed and I make them undepressed, will that affect the way that they make decisions that will effectively improve their economic condition? And for that, that's a really hard thing to do without doing basically a randomized control trial. So what's very commonly used in medicine, and now basically also extremely commonly used in economics, and in particular in development economics. You might be also familiar with the fact that last year's Nobel Prize winners were Esther Duflo, Abhijit Banerjee, and Michael Kramer, and they won precisely for basically introducing and bringing to development economics the methodology of RCTs on a very large scale. And so this is what we use now in order to evaluate sort of what is the causal effect of some particular thing that we care about, but also to have a rigorous evaluation of a policy or a program to really be able to understand truly what works. And with the randomized control trial, because we randomized who receives treatment, in this case, this would be, sorry, my fault, got a little bit. By randomizing who receives the treatment, we know that the people who are receiving the treatment and the people who are not receiving the treatment, the control group, they are not really different from each other because they've been randomly assigned. If I offered the treatment to people, of course I would have different types of people who would say yes versus to the treatment, and so I would never be able to disentangle the effects of the treatment versus the effects of the types of people. So randomization and randomized controlled trial, they are the gold standard for evaluating what the causal effects are. And in this particular case, we want a randomized control trial, of course, not one that makes people more depressed, that's unethical, but one that ideally treats depression or treats other mental health conditions. And if we have randomized control trials to do that, then we can see whether or not, A, are they effective at improving mental health? And B, then do they subsequently affect economic decisions? And if they do, then it would provide some evidence towards this psychological poverty trap, this vicious cycle. And what that also means, if we do find evidence of this vicious cycle, it means that we should be spending money and we should be putting resources and thinking about how to incorporate psychological treatments along with other types of aid activities, because that would make them a lot more effective and allow them to continue to build on each other. So how do we improve mental health. So in order to sort of get at the impacts of mental health on decision making, we could, how do we improve people's mental health? Well, we can give people cash. Sorry, I don't know why it moves in that direction. We can, I mean, so in general, so without even trying to understand this particular link, let us just try to see what are ways that we know of that can improve people's mental health. Well, one I already told you is that we can give people cash. So we can alleviate poverty, and this will improve mental health. So Give Directly has shown that, other types of interventions have shown that. We can actually conduct psychological interventions. So these can be psychotherapy, like cognitive behavioral therapy, behavioral activation, interpersonal therapy, those types of things. There's pharmacology, SSRIs, for example. You can give people antidepressants. There are other types of interventions that are psychologically based, for example, positive psychology, gratitude-based interventions, things that are a little bit less clinical, if you will. So they're sort of more targeted at trying to improve mental health of the general population rather than treat a particular disorder that has been sort of diagnosed. And so there have been studies, and I'll talk a little bit about this, about how effective these are. We can also try other things like improving physical health. We can reduce uncertainty via by introducing insurance, for example, crop insurance for people, health insurance for people, and these might be really interesting. These policies might have like sort of extra benefits to mental health above and beyond cash. So you can sort of introduce an insurance program that might not pay out as nearly as much as what you would have to pay for Give Directly, but if you reduce the uncertainty itself is the thing that weighs on people's minds, and so you can do a lot more with bang for your buck in terms of mental health interventions, as if you're just trying to target mental health by reducing uncertainty. So this is a potential. We don't know if that's true yet. This is a question. We have evidence on, certainly, as I said, cash. We have evidence on psychological interventions on how they impact mental health. So let me talk a little bit about that, because there's some really interesting studies here. So for one, there's going to be a recent paper. It's so recent that it's not out yet, but it will be out in Science soon, by Ridley, Schellbach, and Patel, and so there's some economists and also a global mental health expert, Vikram Patel, and they have written a paper which is really nice, which I can make available the citations if you want to look into that paper. But basically, they're looking at like all of these questions about psychology of poverty, depression, and there's sort of the ways, and they go into a lot of detail on all of the mechanisms, a lot of the things in the arrows that I haven't been able to flesh out in my short talk here. But one of the things that they have from their paper that I think you can see here, these are all these different types of programs of cash transfers. A lot of them are RCTs, and they look at various measures of psychological well-being. So not necessarily just depression, but they're depression, stress, etc. So a lot of, broadly speaking, psychological well-being measures. And they find that basically all of these programs have significant effects across the board, especially when pooled, on psychological well-being. Here's another example from a specific paper. It's not here, but it's one in, it's a really interesting one that looks at suicides as an outcome. And it shows, this is the effect of cash transfers on suicide rates in Indonesia, basically. And so cash transfers reduce suicide rates by a significant proportion, but this is quite substantially larger for districts that have experienced a negative income shock, so droughts. So individuals who experience negative shocks, they are much more benefited by these cash transfers than individuals who have fewer shocks during the period of the study. And so cash transfers provides a buffer to, so basically in all of these directions, what we're seeing is that cash transfers and providing cash improves sort of psychological well-being as measured by various sort of surveys, as well as things like hard measures like suicide rates. And it's a caveat here, or not a caveat, I think one thing to point out about this study that I'm citing here is that it's pretty rare to have good causal impacts on be able to show causal impacts on suicide rates, because they are, although they're obviously very sad and tragic, they are fairly rare from a data perspective, such that if you're looking at an RCT, for example, you're not going to be powered enough. You're not going to have a large enough sample to actually statistically distinguish between one type of like the treatment or the control group, unless you have basically like hundreds and hundreds of thousands of people. And so one of the ways around this was to use other types of research designs. In this case, the cash transfer was a government cash transfer that Indonesia rolled out, and there was a different design that allowed the researchers to sort of effectively look for what's sort of like a quasi-experiment. So, but really, like, all of evidence points to the fact that we can definitely improve mental health by providing people cash. That is good. Now, in terms of psychological treatments, in particular in low and middle income countries, obviously we know that psychotherapy and pharmacology and those types of things work in high income countries, but how have they actually been evaluated? Have they been studied in low income countries or low and middle income countries? That's the acronym there, and there's actually been a fair amount of research on this, and you can see that in about 27 randomized controlled trials that have actually been studied, where psychological treatments were provided. And just to give you a sense of what these look like, these are all psychotherapeutic rather than the pharmacological. So they're psychotherapy, talk therapy, that kind of stuff. They're not medication like SSRIs. And so these ones, the way that they usually work, although they have also been done in low and middle income countries, but less so actually. So basically in these cases, we see usually something like 10 to around 10 face-to-face sessions. And often, as what you can imagine in developing countries, is that there are no sort of registered psychiatrists or clinical psychiatrists that are widely available. There might be one or two in the major city, but really not accessible. There's very, very few psychiatrists or psychologists to actually do this. And so often these interventions are actually delivered by trained community health workers. So these would be the health workers who typically would be, would have something like a high school education. And often they're women, because a lot of what they do often is a lot of pre and postnatal care, vaccination programs, really like somewhat basic healthcare provision. Other types of interventions are also delivered by peers. So other people who are well and basically trained to deliver a psychological intervention. And from these studies, from these 27 RCTs, what we know is that they're highly effective. So they basically, on average, improve mental health by something like a half a standard deviation. So that's a good it's a good sign. So you can check out this paper if you're interested more on the lessons from this. You can see Vikram Patel's also on this paper, and it's a really nice overview of the different types of lessons that we've learned so far on actually providing psychological treatments in developing countries. And so I was surprised to learn when I sort of started working on this that there was as much was done in developing countries as there was actually. So it seems to be that there's a substantial amount of evidence, but the funding towards actually programming is not yet there. Although it's changing. All right, so one of the things that we know, so we know cash improves mental health. We know pharmacology, which I didn't show you, but like, I guess you can sort of believe me that if we can give people SSRIs, that does improve their depression, although there's questions on how long lasting that is. Do you need to keep them on SSRIs? Do people sort of get worse once they take them off? That seems to be the case. Positive psychology and gratitude interventions, the light touch kind of stuff, it's meant to be less clinical. We tried that actually in Kenya. We did one as well, and we did not find any effects. That these did not improve, despite like some literature on this in psychology. It's with very small samples, and when we did it with a larger sample and like very rigorous measurements, and where we actually saw and knew that people were, following along with the protocol, we didn't really find any effects at all on psychological well-being in any way. And so it's not so clear that these would really help. So these very light touch, as I would call them, interventions, probably not what we want to be focusing on. But the types of psychotherapy, like cognitive behavioral therapy and other types of psychotherapy, have been shown to be effective in developing countries and developed countries sort of across the board. They've been really, really well established. Okay, so I showed you that there's a bunch of different ways that we can improve mental health. Some of these ways include cash. So providing cash to people, obviously, to study whether then mental health impacts something else, we can't do that because we've just provided them cash. So the treatment is cash, not treating mental health. So in order to actually understand how mental health impacts economic decision making, what I need to do is change their mental health without changing these other constraints. So in other words, without providing them cash, obviously. So I need to do it using RCTs in what I had just shown you, these types of psychotherapy RCTs, where we could be a bit more confident that what we're changing is just mental health and not, other things like the amount of cash that they have on hand, obviously. So we want to focus specifically on psychological interventions in order to then learn what the subsequent effects are on decision making. And so this is some of my research that I will briefly mention here, in part because it's sort of a good example of a psychological intervention that was conducted in rural Pakistan. It was called the Thinking Healthy program. And it was a program actually that was developed specifically so that it was, training community health workers, as I mentioned. So it's a common model at this point, but it was one of the first to do this on a large scale. And so this Thinking Healthy program was actually developed in a way such that there was a manual that was developed, and it was adopted by the WHO as sort of the standard course of, sort of suggested course of treatment for treating maternal depression in low-income countries. So I'm gonna, just like sort of blasting through this, but maternal depression is, of course, a type of depression, but it happens around the time of childbirth, which is a particularly stressful time, as you can imagine, for families and for mothers in particular, because, there's a lot of stress involved with childbirth and child care during this time. But it is maternal depression in terms of a clinical sort of diagnosis and the way that it's treated is basically the same as other types of depression. So it's all just one. It just is around. It's just, for us, we know that it is very common. It's more common than other types of depression. in part because of the stress that's involved with childbirth, but it also is something, you know, that is also easily targeted. So we can screen people for maternal depression because they're more likely to be in a health center in the developing world. They're more likely to like come in for a prenatal checkup. We can screen them and we can identify them. We can also develop a training manual that's highly targeted towards treating the types of sort of negative feedback loops that are in the mother's minds, because a lot of their concerns are very similar. If you want to develop interventions, psychotherapy interventions that are very scalable, that would treat any type of depression or depression that's sort of caused by many different types of sources, that will require a much more skilled practitioner or skilled therapist, whoever it is that's delivering the therapy. It will require a lot more skill on their behalf, because you have just a lot more sources of, you know, sort of triggers for the individual who is suffering from ill health. So this is an interesting intervention, also because it was one of the largest psychotherapy trials that was ever conducted in the world. So not just like the developing world, it was in the world. So it's about 1,000 women who were enrolled in the study. And it was shown to be super effective. So here's the sort of the Lancet, the initial study that looked at whether or not it was effective in the first year at reducing maternal depression. It was extremely effective at reducing maternal depression within the first year. So this was a good setting for us as an economist, or me as an economist and my team, to go and then subsequently follow up with these mothers and to see how they changed their economic behavior. So in this case, it's rural Pakistan, and primarily these women are not working in the labor force. They're primarily working at home. They've just had children. And so what they do is they're primarily looking after the children and making sure their children are, you know, doing well, that they're going to school, that they're, you know, studying, and so on, that they're eating well. So all of those things. And child rearing is a type of work, of course, it's unpaid, but it is an important type of work. And within economics, this is a very, you know, what we would call development of human capital. So, you know, having higher levels of human capital, you know, what you do when you go to university, you're gaining human capital. It's in part to then become an adult who works and is using that human capital to generate income for yourself. So it's really an important step. And a lot of the human capital processes actually start very early, in early childhood. And so it's really important, the home environment and the parenting and parental investments are really important investments. And so the question that we have in this paper is, can we then look to see whether this type of an intervention, which really was about treating mother's depression, does it have effects on the way that the mother behaves in terms of her investments for her children, in terms of how she controls the finances in the household, because she's not working. So we can't really look at, like, you know, whether she's working and how productive she is at work, but she's working at home. And so we can see what she's doing with the money when she is able to control it. Where does that go? So that's basically what we did. And in this paper, here's essentially what we found. I should note, the study was conducted in basically 2006, and so it's published. The first bit is in 2008. We followed up with the mothers actually 7 years after the psychotherapy concluded. So this is a long-term evaluation. So we're going to see, like, what are the effects of the, you know, treating depression, but also how persistent are they? Are there persistent effects that really last a long time? So one of the things that we find that is actually novel, even from a medical perspective, is that the intervention, so one sort of, not dose, but like one course of psychotherapy, which only lasted for about 11 months, so 16 sessions over 11 months, they had persistent effects. Even 7 years after the therapy concluded, we know that nobody had access to any type of psychological treatment or psychiatric treatment at all at any point afterwards, either the treatment or the control group. No one had it. But we still see that being treated 7 years ago or 8 years ago at this point still has a beneficial effect on people's mental health, on women's mental health. So it reduced depression severity. It had a protective effect even 8 years later. So that was a really remarkable finding. Something that we don't think that SSRIs will do. We think that, like with SSRIs, as soon as you stop, the people will rebound. But there does seem to be something about psychotherapy where people might learn. So, you know, they might learn a skill to cope and to better sort of treat themselves if they are starting to feel unwell. And then when we look at subsequently the economic decisions of the mother, so we look at her financial empowerment, we look at the monetary and time investment of the mother, what we're seeing is very significant beneficial effects, like I said, 7 years later. So we see that mothers are more likely to control the money in the household, which is actually important because this is in rural Pakistan, so women don't have a lot of financial autonomy. But we know that in general, in developing countries, when women gain financial autonomy, when they are able to get control over the resources, they do tend to spend it on things like education and their children. And so we see things that are also consistent with that. So we see higher parental investments. We see more monetary investment in the children. They're more likely to go to private schools, for example, which are sort of slightly better schools in these areas. There's a lot of private schools in Pakistan. It's like not like, and they're not as expensive as the ones here, as you can imagine, but they are of higher quality. We see that kind of investment. We see, you know, more books at home. We also see that parents, in particular the mothers, are spending more time with their children, so spending more time intensive in investment. But we're not seeing we didn't actually see any impacts of fertility. And I won't mention parenting style because it's complicated in how it was measured. So one of the things that we thought might be happening was, well, are these long-term effects that we might be seeing on empowerment, on monetary and, you know, time-intensive investments, all these investment behaviors, could it be driven by the fact that we had this depression intervention 7 years ago, and what it actually did was it changed fertility rates. So it affected the way that, you know, women, it maybe perhaps reduced fertility rates. This is a context where fertility rates are really high, but we didn't actually see that. And what it basically tells us is it's not the mechanism. That's not what's driving these longer term effects on depression severity, on empowerment, on investment, and so on. Okay, so I won't mention the effects on the children, but then I think the question that comes to my mind then from like an effective altruism perspective is, given that we know that there are these interventions, the Thinking Healthy program, for example, which is actually fairly cheap to deliver, something like $10 per woman that was treated, and that, you know, that's all 16 sessions. There are other interventions that are now actually being developed and rolled out and evaluated, for example, Strong Minds in Uganda, and that's being evaluated by a team of researchers, including at the World Bank. So should we be investing in these psychological interventions, or should we just give people cash, really? And should, you know, will the cash just sort of perpetuate itself into better mental health? And how much cash do we need to give people? And what is the most, you know, cost effective? What is most sustainable? What is the most scalable? So obviously giving people cash is not so sustainable, obviously, because you need to get cash from somewhere, but it is very easily scalable, right? So we've seen it very easy to develop, to give cash. In terms of providing community health workers training to treat mental health conditions, that is something that is potentially sustainable, and it can be scalable. And there's a lot of research, including some of my own ongoing research in Pakistan, that is looking at how we can scale up, because fundamentally the number of people who are able to deliver these interventions, these psychological interventions, is limited. There's still, you know, the community health workers are actually very busy. So they're already doing a bunch of other important stuff. So we need to be able to scale this up. Even if the cost is low, there's still a lack of human capability that we need to fill in. So one of the things that I thought was interesting, and what I'll show you as well, how long, I've been talking for a million years, haven't I? Yeah, okay, I'm almost done. One of the things that I thought was really interesting was this paper that actually combined both the cash transfers and a cognitive behavioral based type therapy intervention in one go. And it was run instead of by a team of psychologists and psychiatrists, which is typically who does the interventions that I've mentioned that have been very effective. It was run by like a team of just help or aid, like a, you know, give directly basically, and some economists. So it was meant to see whether, you know, something that is a bit more scalable could be effective. And so then they also interacted both cash and the intervention that treated, rather the psychological intervention. This is called Problem Management Plus. And so it's another type of intervention. Also that the WHO also has a nice protocol about that, how to run that. So basically what they find is what we already know: the cash transfers effect. So you could see these are the significant effects are the ones that are not grayed out a little. You can basically see that when it's just the psychological intervention by itself, it's actually not effective. They didn't find any effect. And this is a huge sample size. I think this is like, you know, over 4,000 people, so quite large. And they don't find any effect on psychological well-being. And this is a psychological intervention. And so the challenge here is clearly that what we see and what we already know is that, you know, providing cash improves psychological well-being, but providing a poor version or somehow a not targeted enough version of a psychological disorder or psychological intervention doesn't have any effect. So again, it's not so easy to actually run these in a way that is that it is effective, basically. Okay, so I'll just end on that note for that, for the whole sort of, what we know is that psychological interventions can be effective, but it's not so easy necessarily. So we're still trying to figure out exactly what the right amount of effort on behalf of the implementers is in order to actually improve psychological well-being. That's still something that we don't know. We know if we put in a lot of effort, we can do it, and we get like all the experts on board, good, we can do that. But if we don't, we haven't quite found this sort of scalable, readily adaptable and available psychological intervention that is actually beneficial in developing countries. So I have one slide on mental health and poverty and COVID, because I think people will ask about that. Obviously, I don't have answers for you here. What we know is there will be some answers. For one, in terms of economics papers, for example, the percentage of papers that are on COVID-19 by May was like 50% of papers that were, I mean, this is for one working paper series. So basically there's, you know, thousands and thousands of papers that are coming out on COVID, not all of them obviously on mental health, but a lot of them are talking about mental health. One that's interesting that has just, that'll probably come out fairly soon, is one that follows college students in the US. And so you could basically see what happens to people's mental health just before to just after COVID hit. And we basically know that the rates of depression, or at least according to the study, which you can't quite see, they go up. They go up in a way that like almost double. They almost double. So something like 30% of college students in the US, or in their sample, are sort of screen positive for depression. And then after COVID, it's something like 60%. So it doubles, which is a crazy amount. That's the majority of students who apparently screen positive for depression. So clearly, you know, psychological well-being during COVID is on everyone's radar, both in the developed and the developing world. And so this is in the US. There is a study, I know at least one study that looks at the impacts, that is going to be studying the impacts of a telecounseling intervention in Bangladesh for women. And so this will be really interesting. I don't know exactly, you know, this is just a pre-analysis plan. So we don't have any effects yet. We don't know how that'll go, but this will be a very interesting, you know, there'll be probably many of these that will be coming out where we can see whether or not telecounseling might be something that might be effective. And if we find that it is effective during COVID, it is clearly going to be something that we can take forward with us, you know, obviously going forward as well, even after COVID restrictions are lifted and people are not necessarily having to be on the phone, but it could be an easy and scalable way of providing counseling and therapy for people in the developing world. All right, I'm sorry I went over time. Thank you. I have a lot of references here to the things here if you would like, but I will end and take some questions.
Yeah, wow. Thank you for that, Dr. Baranov. That's a lot to take in. We'll now move into a Q&A, so please ask your questions in the chat below. And we also encourage everyone to turn their cameras on if they would like to do so as well. I'll just start with Ashay, who asks, other than poverty and maternal depression, what other major factors impact mental health in developing nations?
That's a great question. So it's pretty common in, you know, basically any sort of negative shocks are bad for mental health. So negative income shocks, death, negative health shocks, those are mostly, you know, those impact mental health. We actually also know a little bit about shocks that you experience, you know, even if you're in the womb. So, you know, if you happen to experience a drought in the womb, you would be more likely to have poor mental health as an adult. So there's been a bit of research on that. There are potentially like air pollution is one other example, which is almost direct in the sense that we have some evidence that there is, you know, air pollution both, you know, affects your ability to go outside and do things, but also, as you guys probably remember from the fires, but also there's direct sort of neurotoxicity, neurological effects of pollutants as they actually enter your brain that seem to not be great for your mental health. So there's actually quite a few factors, and many, too many to list. It's partly why it's so difficult to study mental health, because it's quite confounded. A lot of things affect mental health. Yeah.
Yeah. I think Patrick had a question he wanted to ask.
So, yeah.
Thank you.
Hi, Patrick.
Hi, Victoria. How are you?
How are you?
I'm good, thank you. Great talk. I thought it was really interesting because I guess mental health is something we don't think about a lot in terms of the developing nations. Just when you were speaking about the randomized control trials that are backing some of these initiatives, I guess it made me think about trials and initiatives in developing nations in general, and about how evidence-based a lot of them are. So I guess my question is, in terms of initiatives focused on improving global, like physical health or global mental health in developing nations, how many of them do you think actually have had this like rigorous testing done behind them?
That's a great question. I mean, I think it's really hard because it's like, how do you define an initiative, I suppose? But there is a pretty large push to evaluate them, that whether or not, you know, people are listening to the research and actually, you know, implementing what is evidence-based versus what is not. I think that there's been a shift, a bigger shift towards that, both, you know, even within local governments in developing countries. I think that there's now more evidence-based policy making. In fact, in some cases, one could argue there's more evidence-based policy making in developing countries than there are in developed countries. But I think like you know, putting a number, I'm not sure that I could put a number on it. So it's definitely growing substantially. There is, and it's growing a lot. Like it is sort of the buzzword with all of the aid organizations, right? So whatever they do, they're trying to either figure out, they're trying to either just implement something that they know works based on the sort of rigorous evidence base, or they're trying to sort of actually evaluate it in a way where they can see whether it works or not. So there's been a huge push towards that for aid organizations. And then, yeah, just for policy, government aid, you know, that's to the extent that it's not, you know, politically captured, because obviously, like, you know, policymakers might want to do something that is rigorously backed, but then it becomes political and complex. So yeah, but I think like it's definitely like trending up. Yeah, that is a question.
Awesome, thank you.
Awesome. I think we might be running short on time. We probably only have time for another 2 questions, if that's possible. I'll ask, so I'm curious as to whether effective altruism or your own philosophy has influenced the choices you have made throughout your life or career, if at all.
So I think so, but I don't know that I would have called it effective altruism. I think it's just sort of the economist mentality where, you know, I'm really concerned about efficiency. So efficient, you know, trying to do things in a most efficient way. It's just sort of burned into my brain a bit. And of course, then that means that I'm going to try to figure out what is, you know, how to spend my time in a way that is most productive for other people and for the world. And so it's definitely there in terms of how I think of it and you know, the research that I do, but also sort of the types of other activities that I invest in terms of giving and stuff has always been sort of motivated by like, well, what's the most good that I can do? But I think this is inherent in sort of the economic philosophy
Yeah.
as well.
Okay.
So.
Thank you. And yeah, I think that's everything.
I mean, I can answer some of the questions because one person asked about whether there was, you know, other charities to improve mental health. There's at least one I know that is very good in India. And it is called, I think, Sangath, which is really good for, that's been working a lot on mental health. And so this is, I don't know if I can link to that. I can probably send it to someone if it, just to make sure that I have the right website for them. But there's that one. I don't know about that many more. And then, yeah, and if you, there's a couple more questions that I'm happy to answer for, so Lauren, Sarah, that I'm happy to stick afterwards and answer those, but I want to like leave others to, I think that's right. Yeah, I think it's, yeah, thank you so much for having me and apologies for going over time.
Not a problem. I guess we'll just quickly do one more. Lauren asks, do mental health interventions seem to be more persistent in less developed countries because of their paucity, or would you expect similarly long-lasting effects in developed nations?
That's a great question. So I think one of the things that we do see in developed countries is basically that, at least when you evaluate these things, right, you have a treatment and a control group, and you can treat them, the treatment group, and then like let them be for a while. And one of the things is that in developed countries, even the control group eventually is going to find treatment. It's very typical that you'll probably, you know, if you need it, you'll get help. There is a lot more of it available, and so it tends to be what happens is that, you know, the control group in some way or another will get treatment. And so it's exactly as you say, because in developed countries, there's not like a paucity for treatment. There's a little bit more awareness. And so that it doesn't, yeah, basically it looks like it's less effective over the long term. It's not that. It's just that like people will eventually get treatment. Whereas in developing countries, there is no other treatment. And so really like you're just seeing the difference between like the real difference between not ever treating someone and then treating someone once. That makes sense.
Sarah asks, what is the importance of scalability in development projects, especially for those regarding mental health?
Yeah, I think that's also a really good question. So I think that scalability is key. So like the first papers are often like sort of proof of concept, where they say, okay, we're going to develop this intervention. So if they say, for example, this Thinking Healthy program, which we did, where, you know, we had the community health workers that were trained. And so they took their time to be trained to then deliver the intervention. And we know that it can work given the appropriate training with community health workers. The next step, though, of course, is how do we get this out to as many people as possible in a way that is effective? And for that, we need to scale. And so however effective our proof of concept, you know, trial is, it is not going to be meaningful in any way if it breaks down as soon as you try to scale it up. Because maybe the, you know, community health workers just don't have time to do this, and so they just don't deliver the intervention. Or, you know, if the way that you train the other people that are not community health workers don't understand how to do it properly, and then, you know, they end up not actually having any beneficial effect. And so it is actually where most things break down in not just mental health interventions, but in any type of intervention. Scale is the thing that basically kills all projects, is, you know, trying to go to scale. And it is a real challenge, and it's something that I still, you know, we continue to be really, you know, struggling with, trying to figure out what scales and what doesn't. Apart from cash transfers, which appears that scale well.
Yes. And I think the last one will just come from Lauren. Is there any way to get more involved, maybe aside from donating money to charities?
Yeah. I think that there is, in terms of how you would be able to, I mean, I guess you could get involved in the research side. There are a lot of organizations that are doing like basically randomized control trials within this stuff. So if you like are interested in doing research, like an RA, there is the Poverty Action Lab that's based out of MIT, but they have branches all over the world, as well as Innovations for Poverty Action. I know a lot of these organizations are running various types of interventions along the lines of mental health. And so one thing that could be done where you could actually like be in the field and work, I mean, once I guess COVID restrictions let up. Apart from that, that's a good question. I actually don't know. I don't have a direct way of getting involved. You couldn't get involved locally. I know you could be, you could like offer to counsel people over the phone. I know that mental health care in Australia is actually quite lacking. So that's something that you could do as well. So locally, you can definitely look things up. I think, like Beyond Blue and various other sort of organizations probably have lots of, volunteering that you could do to help them as well. And especially now during COVID, I think that they're well oversubscribed.
Yeah, great. I think that's something we should definitely look into. I think that is everything. So I'd just like to thank you, Victoria, for taking the time to speak to us today. Mental health is obviously becoming an increasingly important factor to consider in our lives, and something that's been overlooked in developing countries when considering forms of aid and social welfare programs. And yeah, thank you once again. It was a super interesting and educational talk. I know I learned a lot, but I'm sure that everyone will be leaving today feeling a little bit more educated about mental health in the developing world and the work that is being done and still needs to be done. If you guys have any additional questions, you can just contact Dr. Baranov by email, which we'll put in a discussion post on the event page. And yes, that is everything. We do have a couple more social events lined up the rest of the semester, which we'd love if you all attended. They're all up on our Facebook page. Yeah, if you'd like to stick around, we'll also do a bit of a quick chat waterfall just to get some of your thoughts on the events, and we'll appreciate any feedback given. So yeah, thank you.
Thank you for having me.